Have made it to shaken baby syndrome, mechanisms, risks, and prevention across care systems. So we are so excited to be able to offer you this training today, especially with such experienced people in this field. And so you're going to be learning a little bit more about some biomechanical forces. I'm going to say these words so wrong because I'm not in this field, but sentinel, is that right? Oh, yay! Woo! Injuries, signs and symptoms, and long-term consequences for infants and families. You're also going to learn a few more things about how you're working with that, things that you can do. And I'm learning right along with you. So I am excited to be here as well. Let's talk about who is going to be presenting for us today as well. So on the next slide, we have Danielle Vasquez and Chantel Wakely. They are here from the National Center on Shaken Baby Syndrome. And Chantel is the Purple Program Director, and Danielle is the Executive Director. Danielle has nearly 16 years of experience in abusive head trauma prevention. Chantel has spent the past 5 years advocating for awareness and training initiatives. They both are very, very passionate about advocating for shaken baby syndrome, children who are experiencing things. Danielle also holds a degree in social work and psychology. And Chantel leads global partnerships to support education and prevention efforts in this field. And so, with that being said, I will go ahead and turn it over and they can get started.
All right. Thank you so much for having us. Before we get started, I just want to say that when my son was 3, his favorite color was sparkly rainbow. And from here on out, that will always be my most favorite color is sparkly rainbow. So there you go. Um, so thank you again for this opportunity. We really appreciate it. As I mentioned, my name is Danielle Vasquez. I am the Executive Director for the National Center on Shaken Baby Syndrome. Just a little bit about who we are. We are a national entity. We serve locations throughout North America, but we also actually partner with different countries throughout the world, helping form different prevention strategies, trainings, conferences, just educational opportunities to help both the professional side and those families that have new babies in their lives. On the professional side, we really work with anyone that's serving a family that has a baby under that 1 year of age. We've been really lucky to partner with the leading experts and leading institutions across the world to make sure that we're providing the most research, the newest research-based education and strategies on everything from diagnosis to treatment to legal, the legal aspects of these cases. Additionally, we host a conference every 2 years here in North America. Next year will be in Nashville, Tennessee. And again, it's a very, it brings together people from all over the world, and we focus on multiple different disciplines: medical, legal, investigative, CPS, nursing, prevention. And then we also have a contingent of families of victims of shaken baby syndrome that attend. Our research-based resources really reach over 1 million people worldwide each year. So we're really lucky to have this opportunity to spread even more awareness. So the question we get a lot is, what is shaken baby syndrome and why are we taking shaken baby syndrome and abusive head trauma? So abusive head trauma is more of an umbrella an umbrella term. It means any form of severe physical in a child abuse that results in a head injury. So that could be shaken alone or shaken with impact as well. So abusive head trauma is an injury to the skull itself and the contents within that skull due to that trauma, that shaking or that blunt impact. And shaken baby syndrome, abusive head trauma is still a leading cause of mortality in infants due to physical abuse. So it's a significantly damaging form of abuse.
There have been some very elegant studies with models of infants and shaking that really demonstrate what we've known all along, that shaken babies is extraordinarily dangerous. It can severely injure or kill a baby. And those who say that the physical experiments don't prove that are just wrong. So what's happened over time is that we have discovered that as the brain grows and matures, it still is very susceptible, particularly in the younger ages, but on up to maybe a year or a little past a year, to violent force. And when you shake a baby, 2 or 3 things happen. One is most shaking is back and forth, and when you do that, the brain then bounces in the head. Excuse me, it bounces in the head a little bit, actually a lot, and that can tear the different components inside the brain, mostly cells that are neurons, nervous system cells in the brain. It can cause distortion of the brain matter, which puts things in positions that they're not supposed to be in. And the culmination of that can be a severe brain injury and sometimes, unfortunately, frequently death, because the human brain is so pliable and flexible that inside this skull, even though the baby's skull is malleable because it's made up of separate bones that have not yet fused together, inside that skull, and with the extension of the brain down into the neck area, and the anatomy of that can be very easily, when forcefully distorted, can be very easily damaged.
So as Dr. Block was mentioning, the shaking mechanisms that result in abusive head trauma are very complex. There's a lot of factors that come into that. First, the head size. The head is a lot bigger in an infant compared to the rest of the body, and they're supported by weak neck muscles. Additionally, the brain is still only partially myelinated at this early stage. So that means it contains an increased water, resulting kind of in that soft gelatinous organ still. And that's really susceptible to distortion. And the white and gray matter, they differ in consistency and in mass. So that difference can also add to how they're more prone to brain trauma than say an adult. And as he mentioned too, the skull is still connected by those loosely curved plates. Those aren't fused together yet. And they're fused by very soft membranes. So that has a lot to do with the injuries as well. So when you shake a baby, there is a rapid acceleration and deceleration movement in that brain. I'll show you a clip here in just a second. So those that the structure of the brain, the skull, they'll move at different speeds in different locations. So those veins that are anchoring everything together, they're starting to tear, they'll stretch, and it's all due to that rotational movement. And then that actually leads to a lot of bleeding. We'll see when those vessels and those veins will break, there'll be a culmination of blood in different areas under the dura or under the arachnoid layers of the membranes covering the brain. And we'll go further again into this, but there's some other potential injuries like subdural hemorrhages, subarachnoid hemorrhages, and retinal hemorrhages. So as I mentioned, this is a clip. As you can see, the head's going to go back kind of in a whip-like motion, almost in a figure 8. And it's that violent back and forth. A couple of other factors I haven't mentioned is the person that's doing the shaking is much bigger and stronger than the infant. So that force is going to be very, very violent. And then this is the image of the brain, kind of some of the injuries I was talking about. As you can see, those bridging vessels up there, those blue, they start moving in opposite directions. And that's when you're going to cause a lot of those issues, that breaking, those hemorrhages, and some of the edemas. You can see here as that brain bleeds, you're actually going to get swelling as well in that brain. So, and then as I mentioned, retinal hemorrhages is also something that you'll see in a case of shaken baby syndrome, abusive head trauma. This animation kind of shows you those mechanical stresses caused by the shaking. It causes damages both inside the eye and around the optic nerve and muscles. So the rapid acceleration, deceleration we've been talking about also causes the retina to tear. And this produces different kinds of bleeding or hemorrhages, as you'll hear, both in the back and in the front of the eye. So no one actually knows how much force is produced, or how much force is needed to produce these injuries. Obviously, we can't test that on a live infant. There has been a lot of biomechanical studies with dolls, with computers. They've used like pigs and rats and things like that. Computers are slowly getting closer and closer with AI, but nobody really knows. There's so many variables too to be considered, such as the age of the victim, the strength of the perpetrator, the duration of the shaking and the severity of the shaking, and the presence and absence of impact is also to be considered. But just remember, this is a violent and sustained shaking with or with impact. And it's thought by most clinicians who to produce these injuries, sorry, let me rephrase this, like with it's violent and sustained. That's what most clinicians think. And then information from convicted perpetrators who have described their actions after shaking a child, that the duration of the shaking may be a few seconds, as much as to 20 seconds or even longer. So some of the injuries that also come with it, like I've mentioned, some of the injuries that happen in the brain, but they'll actually be fractures if there's a blunt object involved with that. You'll see fractures in the skull. We've talked about the eye injuries, but you'll also see bruising along different parts of the body. You'll see fractures that can be in the ribs and the long bone, like your femur and leg, in the leg bone, and then frenular tears. That's the little part that connects your lip to your gums, that will sometimes be torn or have contusions on it as well. Sentinel injuries. Why are we talking about sentinel injuries and what are they? So sentinel injuries is bruising in an infant, and it's really an indicator of abuse in non-mobile children. So when you're seeing a child that has a bruise behind their ear, on their cheek, on their neck, and they don't crawl, they don't roll, that's a big indicator, and it's something that pediatricians, other clinicians are really starting to look for, because if we can identify those sentinel injuries before, identify that there is risk factors for this child being abused, then hopefully we can stop it before they're more severely abused, like being shaken. So again, it's a very fairly minor abusive injury, bruising and things like that I mentioned, but a huge indicator. So about over 27% of abused infants have had previous sentinel injuries. And sentinel injuries can happen in early infants. Over 66% are when the infant is less than 3 months of age, and 95% are before the age of 7 months. So again, 7 months old, most babies are not crawling by 7 months. They're maybe rolling over, but they're not going to be getting those like bumps from hitting a wall when they're crawling or falling off of furniture, things like that. So it's a really strong indicator. But then it's also important to know, as I said, they're just barely starting to talk about. So doctors are only reporting that they're only aware of sentinel injuries in about 41% of these cases. So there are more tools now available to recognize these sentinel injuries. One of the most important ones right now that we're seeing is called the 10-4 FACES. And so it's bruising to look for, it helps clinicians look for bruising in the torso, ears, neck, frenulum, that's that part right here I was telling you about, angle of the jaw, cheeks, eyelids, any bruising under to children, again, under that kind of 4 months of age. And the bruising in these regions has a 96% sensitivity and 87% specificity for identifying abuse injuries. When a child is shaken, there's a couple of different things to look for. So milder signs are going to be a decreased appetite, they're lethargic, they have a lower level of consciousness, they may vomit, irritability, trouble sleeping. Some of the severe signs right away are they're going to be unable to make sounds or follow movement, they're going to have problems breathing, or they'll be even turning blue, seizures, unable to suck or swallow, they may be unconscious or unresponsive. So with all of those injuries, there's a lot of consequences that will come with that. If the child survives, because they do pass away from their injuries, they may have cognitive disabilities, physical disabilities. Over 80% of survivors have visual disabilities or blindness, hearing loss, speech disabilities, cerebral palsy, chronic seizures, and even behavior disorders. So one thing that we actually get a lot of questions about, which is great because we really encourage people making sure that they're being careful with the children or children that they're caring for, is, you know, what does and does not cause shaken baby syndrome. So like bouncing your baby on a knee won't cause it, tossing the baby in air, jogging or bicycling with your baby, even falls off the couch or other low-lying furniture, sudden stops in their car, burping your baby. It's a very violent whiplash motion. So it's similar to if a high-speed motor vehicle accident. So little bounces on your knee is not going to cause the same damage that shaking causes.
The neurologist pretty quickly showed us brain scans and just explained that what spots of her brain were gone, died, and that they would never come back, and that she was going to be severely disabled. She's catheterized and she has a colostomy and she has a feeding tube, so she can't do anything. Kind of like caring for a 6-month-old baby is how I explain it sometimes.
When Deacon was injured, he ended up getting life flighted once he was taken to the hospital to a more major medical center where a large portion of his cranium was removed to relieve swelling. A large portion of his skull was absent and it was just skin covering brain tissue.
I was shaken by my father when I was 4 months old. I was rushed to the hospital and my family was told that if I had arrived even a few minutes later, I wouldn't have survived. I was left with complete blindness. I had seizures up until I was about 3 or 4 years old. I'm totally paralyzed from the waist down.
So I forgot to use reactions in the beginning. First, I want to ask if you have any questions, please put them in the chat and then we'll respond to them. I see that there's already one. And then if you are already serving families that maybe have had a victim of shaken baby syndrome, will you just do a thumbs up as a reaction, just so I can see who is already interacting in this field? So one of the questions we got, does shaking cause injury to the cranial nerves? And yes, again, it's different in every case, but there are a lot of injuries to those nerves. We're actually seeing now with technology, because technology is evolving, a lot of spinal cord injuries that they couldn't detect, say 20 years ago, but because of imaging that they can detect that now. And then when and how do you suggest telling someone that they were shaken and that has caused their disability? Well, that's a tough one. I actually don't have a very good answer for you. I have seen all sorts of different scenarios. We work with a survivor who's in her 20s now, and she didn't find out until she was in college, and she was doing a research paper on herself, and she actually found news articles. And I can tell you that definitely is not the way to do it. I can say probably when they're old enough to understand what you're talking about. We have some that are 6, 7, 8 years old that know what happened to them, what they're going through, especially the ones that are have a little bit more high function. And so they actually will talk about it, and it's part of what they're going through. But I think that's something that's probably different for everyone. Any other questions? And then if not, if you have other questions, we'll answer questions at the end too. So we'll just keep on going.
Awesome. Okay, so situational factors. There are triggers that can attribute to the risk of this form of abuse. And while many different things can be a trigger, these are typically the most common. So you have feeding difficulties, Where some infants and young children may have chronic difficulties with feeding, it can cause frustration, especially if a mother figure wants to breastfeed, but the baby isn't latching. Things like that can cause that external frustration. Toilet training difficulties. Parents may have unrealistic expectations of toilet training, which causes that frustration, and just general caregiver frustration. So this can include changes of the home or work dynamic. So that can include, increased number of children in the home who need care, employment stresses, financial problems. But really, any of these can cause a person to lose control. Societal factors can have, impacts. Typically, caregiving advice should result in more good than harm. But unfortunately, there is a lot of inappropriate advice out there. And although it might be from a well meaning source, it can actually produce the latter effect. But lastly, the perceived misbehavior. That is a big trigger. So when infants cry continually, unexpectedly, or unsoothably, tired caregivers may feel that the infants are purposely behaving this way just to frustrate them. But through over 60 years of research on infant crying, it has been found that infant crying, especially increased inconsolable crying, is likely the most common and important trigger for shaking events. And in studies focused on perpetrator confessions, it showed that perpetrators often say that the reason for them shaking the baby was because it would not stop crying. All right, so the crying curve. I want to do a reaction. So find the emojis. So if you have heard about the crying curve, I would like you to send either like a red heart or a thumbs up. If you've not heard about it, let's go ahead and do like a thumbs down or a red X. Okay, so some hearts, awesome. Thumbs up, love it. A couple thumbs down, that's perfect. We love educating people about the crying curve. So if you don't know about it already, here we go. So this slide is just going to demonstrate how increased infant crying, although frustrating, is actually a completely normal developmental phase that all infants experience. And it's a huge situational factor for shaken baby syndrome and abusive head trauma. So some of you may be thinking right now, well, duh, infants cry. I know that. We all know that. But there's been over 60 years of research done on infant crying. And over the years, it's shown that infants cry, but they cry a lot more than most expecting parents and the general population would think. So our understanding of the normality of early increased infant crying actually started with a study by T. Barry Brazelton. So Dr. Brazelton asked mothers of healthy newborns from his practice to take home diaries and record all the fussing and crying that their infants did each day for 3 months. And this figure is from his published article in 1962, which is known as the normal crying curve. And there's two important things to notice about this curve. So first, there is a very clear increase, peak, and then decrease in the number of hours of crying and fussings the infants experienced. The onset was at about 2 weeks of age. The peak was during the second month, and it slowly decreased after that. The second thing to notice is just like weight and height, there's a very large infant to infant variability in the amount of crying that they experience. So what is shown in the shaded purple area represents about 50% of all the infants in the study. So this means that 25% of these normal babies cried less than is shown in the lower line of the shaded area, but 25% of these normal babies cried more. So even though some babies cried less while others cried more, this increased crying is a period that all healthy infants experience. And regardless of whether the babies are born pre or full term, and even despite the vast differences in caregiving behaviors and even species, all the subjects studied showed an age-related crying or distress pattern. So this was great evidence to support the assumption that all babies, in fact, do go through a period of time early in life where they experience an increase, a peak, and then a decrease in inconsolable crying behaviors, and it's completely normal. So in addition, to the anecdotal evidence from parents that have showed how truly frustrating early increased infant crying can be, there was a need to find more convincing evidence of the importance of early increased infant crying for shaken baby syndrome and abusive head trauma. So in earlier studies, it was hypothesized that if crying was a significant stimulus for abusive head trauma, then the pattern of age-related incidents of shaken baby syndrome and abusive head trauma cases should be similar to the age-related properties of the crying curve. So this figure demonstrates their hypothesis was correct. It was a study conducted on publicly reported abusive head trauma cases, and it showed that when they plotted the 591 cases by age, which is the top purple line, the shape of the curve is very similar to the crying curve. With the majority of cases, victims were under 6 months of age, with that peak amount of cases around that 2-month time frame. And so this was strong evidence to show that normal crying and shaking events were related. However, there wasn't direct information showing that crying was the stimulus for the shaking. So they then looked at the 166 cases that mentioned frustration with crying was the specific trigger for the shaking event, which is now the bottom yellow line. And as you can see, both are very similar to the crying curve, with the peak amount of cases at that 2-month time frame. So these studies provided that direct evidence needed to show that crying is likely the most important stimulus for shaken baby syndrome and abusive head trauma cases. But just how common is abusive head trauma? So approximately 1,200 to 1,400 clinically recognized cases occur each year in the United States alone. And that's around 32 to 38 cases per 100,000 children who are less than 1 year old are suffering from abusive head trauma each year. But because 30 to 40% of cases are missed at medical institutions, the actual incidence is unknown despite these prior estimations. And it's actually likely that the known incidence is just the tip of the iceberg of the amount of cases that are occurring each year. And unfortunately, the outcomes for infants who are taken to hospitals are poor. In published studies, as many as 10 to 20% of babies die as a result of being shaken. And of those who survive, 65 to 80% have significant long-term neurological and developmental abnormalities. So over 50% of all victims of shaken baby syndrome and abusive head trauma are under the age of 6 months. But victims range from as young as 7 days old to as old as 58 months. So there are some risk factors, which can include high criers, preterm births, multiple births, or illness. But however, any child can become a victim. And while all victims or all infants are at a risk of becoming victims of shaken baby syndrome, there is evidence suggesting that certain populations may be at an increased risk. So these populations include infants who are under the age of 8 months, with the peak fatalities at that 1 to 2 month age range. It includes male infants who are more likely to suffer from severe abusive head trauma injuries leading to death. These also include infants born to young mothers. There was a study that showed maternal age was associated with infant maltreatment risk until the mother was 28 years of age, with an even higher risk if the mother was less than 22 years of age. And finally, minority children who are more likely to suffer all traumatic brain injuries, whether inflicted or non-inflicted. And for this latter group, it is likely that race and ethnicity act as a marker for other social factors leading to this increased risk. So studies done on perpetrators of shaking events found that fathers are the most common perpetrator, with parent partners second and mothers third. But however, anyone is capable of shaking a baby. A 2022 study showed that children under 1 year of age with siblings under the age of 5 years are more likely to be injured by their biological parents. Other studies have revealed the central role of infant crying in triggering shaking by caregivers. showing that teaching parents about normal infant crying and creating cultural shifts in childcare and discipline prevention is possible. So this demonstrates the importance of all caregivers being engaged in prevention education, which we will discuss in more depth shortly. But in the meantime, is there any questions about what we've gone through? Any triggers, infant crying, anything like that? Once again, just put them in the Q&A since the chat is getting pretty full. The Q&A is the perfect place to put your questions.
I did want to mention there was a question about looking at understanding that milder cases might be missed, in the clientele that you're serving. And that is a factor. A lot of times when they present, it might just present as like a flu symptom or things like that. So I just want to draw back to what Chantel was talking about, that a lot of the known incidents are just a tip of the iceberg, because some of those milder cases really are being missed at medical institutions. So not just amongst kind of the populations served, but even in the ERs and pediatric offices and things like that are missing those cases.
Okay, nothing coming through the Q&A, so we're just gonna keep going.
So one of the things that's brought up a lot is kind of how do they identify a case of shaken baby syndrome, abusive head trauma. So some of the workup that they'll do, mostly if they're at a children's hospital by their trauma response team, some of the things that kind of raise a bit of red flags and require further evaluation is like the history that the person who brought the child in isn't really making sense. The injuries don't correlate with what they said. There's not a consistent history, or that history is changing about that child or infant. If the child is on ambulatory, kind of like we were mentioning before, if they're not able to crawl, if they're not walking, some of the injuries they're going to be less likely to get from like normal toddler crawling or falls and things like that. There's no history of injury. So it's really easy to say, hey, this child's been in a car accident and here's all the proof. And that's very easy to connect those two together. And if that's missing, that's missing. And then a lot of times multiple fractures, as I said, you'll see them in rib fractures, long bones, arms, all kind of all over. And then sometimes fractures in varying ages, which means that this child has been repeatedly abused, unfortunately. And sometimes you'll see a delay in care. Especially if the child isn't presenting with some of those severe symptoms right away, there might be a little bit of a delay in that care, which again, it could obviously lead to the longer you wait for treatment, the more severe and more damaging those injuries will become. So I want to discuss the role of a child abuse pediatrician. You'll see a child abuse pediatrician a lot of times at the children's hospitals with the trauma teams. You're not going to see them at your normal local hospital, in your ERs. These are more associated with those big trauma teams, different child advocacy centers, things like that. So a child abuse pediatrician is now a subspecialty. It was created, I believe, in 2007. There is a lot of different testing fellowships that go into becoming a child abuse pediatrician. And they're really taught to interpret the medical findings differently than a normal pediatrician or a family practitioner. They are able to recognize the presence of abusive and accidental injuries, and they're able to kind of identify what causes certain injuries, what is more prone to cause those type of injuries, and also the general biomechanics of injuries. What causes the long bone fracture? We know that because of all the studies done that when a person is changing a diaper and they're reacting in a frustrating way, and they'll actually grab the baby's leg and they'll pull the baby up. When they do that, it kind of causes a buccal handle fracture, and they know that biomechanical action that causes that long bone fracture. And but they also have the experience with relevant medical diagnosis and the process of a differential diagnosis, and they can interpret laboratory and radiological results. And unfortunately, because there is abuse factor with this, it often leads to criminal charges. And so their role is to also educate the judge and the jury of what's happened in these cases. So because again, there's a lot involved when it comes to a child that's been shaken, there's usually a multidisciplinary team approach. So this is a collaboration of experts to ensure that all the aspects of the child's injuries, their history, their environment, they're carefully reviewed. So it's not just one person going in and saying, hey, this is what's happened. They're going to rely on other specialists that have experience in their area of expertise, and all of those together will kind of combine and give a better picture of what happened to this child. So that in the medical world would be your orthopedics, your ophthalmology, because of the injuries in the eye, critical care. These children often end up in the PICU or ICU, neurology, hematology. So they're going to want to rule out anything. It could be like different genetic disorders, blood disorders, if there's like a vitamin K deficiency or something like that, that could lead to these injuries. Radiology, make sure that they identify all of those injuries and others. But then they're also going to look at other professional fields too, because it's not just the pediatrician that's going to be seeing this case. Law enforcement's now going to be involved, probably child protective services, because if there's going to be criminal charges, your state or district attorney's office, child protection team, medical examiner if the child passes away, different hospital medical personnel, a forensic interviewer, child advocates, kind of others as needed. So it's a very deep group of individuals that will deal with just one case of shaken baby syndrome, abusive head trauma. And this is really just to improve the accuracy of the diagnosis, reduce any bias, ensure that the medical findings and investigations are very thorough and fair. They're not going to want to accuse a family or someone of injuring their child when it could be other causes, just because the ramifications are quite large. So you may have heard, will you do a reaction if you've heard any controversy lately in the media or in your professional field about shaken baby syndrome as a valid diagnosis? You know, for some that might be a weird question. So a few, but not very many, thank goodness. Oh, yep, there they go. There's a couple. So not a ton, but unfortunately, there's this kind of weird movement that we are dealing with right now, that shaken baby syndrome has been termed junk science. You'll see that in the court system, not in the medical community. So I'm just kind of reinforce a few things. So the American Academy in Pediatrics has been doing a lot of statements, policy statements, technical reports that we'll get into in just a second, just to reiterate the fact that shaken baby syndrome is a very valid diagnosis. And it's that subset of abusive head trauma that we're talking about. So just shaking, maybe without impact, just shaking alone, but it's still a very valid diagnosis. And there, as I mentioned, there really isn't much debate in the medical field. It's in the legal field that we're seeing. That's because these cases are very complex. They can lead to serious outcomes, like I said, like a child being removed from their home, someone going to jail or to prison. So it's really just about the legal interpretations of that evidence. So just kind of to continue to combat this misinformation, like I said, the AAP and a couple other groups are really just reiterating that. So there is a team at the AAP that's a committee on child abuse and neglect. They still are a committee. This was in 2001 and it has not changed. So the clinical signs of shaken baby syndrome are immediate and identifiable as problematic, even to parents who are not medically knowledgeable. So it is something, if you see on the side of the street and you see the action, you know immediately that that's a very dangerous behavior and that there's going to be harm to this child. So ABSAC recently came out. They're a big national society, Association for the Prevention of Child Abuse. No, Society for the, oh my gosh. you know what I'm trying to say. I can't even think of it right now. But they said this is what they came out with recently. False controversy exists only in the legal arena. There is no controversy in the relevant medical community among those who are properly trained and regularly diagnose the cause of injuries in children. That's very important. So the ones that are regular seeing these kids. In 2018, a bunch of medical societies around the world came together and formed a consensus statement. I don't think, I can't remember if I sent this on to CalTrin or not as a handout, but if not, it's easily findable on our website. We have on our main page of Learn More. So there's a bunch of different societies, as I mentioned, like the European Society of Pediatric Radiology, the Society of Neuroradiology, APSAC, oh, there it is, American Professional Society on Abuse of Children. So close. Swedish Pediatric Society, American Academy of Pediatrics, they all came out together just to reinforce the validity of shaken baby syndrome, abusive head trauma. This is a handout. If you don't mind popping it there into the chat, it is a free publication and it's a very, very important document. They did such a great job with it. It is quite lengthy. It's like 73 pages or so, but there is chapters and a glossary. It's extremely helpful. They just barely, the American Academy of Pediatrics published their first technical report on abusive head trauma just in February, and it's a very comprehensive literature review on in support of evidence-based medical evaluations to the diagnosis of abusive head trauma. So this, and I think they did just pop out. I think I saw it pop up in the chat. So if anyone's wondering, it is in there now. And just some of the takeaways from it is that is the third leading cause of head trauma in children younger than 5 years old. As Chantel's mentioned, that peak incidence is around 2 months of age, with the median at 4 months of age, and then does decrease again, just like that crying curve. And that mortality rate ranges from 10 to 20%. So this is a really all-encompassing document. It's kind of like the new go-to for anything and everything when it comes to abusive head trauma. So we're really glad that they did their due diligence and found everything there is to know about it and put it in this document for us. So one thing that comes up sometimes, again, mostly in the court system, but something just to be cognitive of is you'll hear, oh, it was a fall. They fell off a couch or a changing table, a bed. But actually those shortfalls don't really show the same injuries that you're going to see in abusive head trauma. There's been a lot of different studies just to reiterate this point. So there is they claimed that children who acquire fatal injuries from shortfalls have suspicious trauma history. So kind of that history we were talking about that isn't really matching up with their injuries. And rough play is also unlikely to cause the same effects as well. I just should mention that, kind of back to the bouncing on the knee and even rougher than that. So really you're seeing 0.48 per 1 million children will pass away from a shortfall. So you're talking the most minuscule part of injuries will cause of a shortfall injury will cause death. And a study on cases of 316 children with a history from the caretaker that the child had fallen were analyzed. 7 deaths occurred in 100 children who fell 4 feet or less. 1 death occurred in 117 children who fell 10 feet to 45 feet. And the 7 children who died from shortfalls all had other factors in their cases, which should suggest false histories. So it's unlikely that history is incorrect when a child incurs fatal injuries in a fall of less than 4 feet. So you'll see too, in part of that false narrative, that there are starting to be cases that are overturned legally due to new medical literature, new medical research, and that is actually not quite accurate either. So Dr. Sandeep Narang, really world-renowned pediatrician and prosecutor, he, does it all, and is brilliant. So he looked at all the overturned SBSHT cases and looked at the characteristics within each of those cases. So he started out with a little over 1,400 SBS convictions with appellate rulings since 2008. 49, so only 3% of those were actually overturned, with only 20 so that's 1% on medical evidence related grounds for being overturned. So, and upon retrial, 42% of those either repled guilty or were convicted again against the same offense. So really, they're not being overturned. When successful, it's not based on new scientific discovery, but on just differing medical opinions. So I bring this up because those that have heard about this controversy more than likely have heard about the Robert Robertson case. This is a case out in Texas. He currently is on death row for shaking his daughter, they believe with blunt force as well. So shaking with impact of his 2-year-old daughter. The execution has been halted numerous times and has garnered a lot of media publicity worldwide because his legal team has said that there has been a change in medical evidence, that shaken baby syndrome is now adjunct science. So that's kind of why I'm telling you all this stuff. So it's not adjunct science, it's still a valid diagnosis. And unfortunately, those phrasing is really being picked up again worldwide. We're seeing it on BBC. Dateline with Esther Holt just did a 4-part podcast talking about medical changes to the shaken baby syndrome diagnosis, even though I just showed there really isn't. It's just in the legal. And then John Grissom is writing a book called Shaken. So that's our concern is if the media is twisting that messaging, that shaking is a false diagnosis, it's adjunct science, that we're putting more infants at risk. I don't want parents to think that it's not going to cause, parents or caregivers, that's not going to cause injuries, because it is. It's very devastating. That debate is just illegal. We don't get into that. That's not really our wheelhouse. Our wheelhouse is prevention, right? We want to make sure that parents are understanding the dangers of shaking a baby. Is there any questions when it comes to the kind of that controversy around shaken baby syndrome? I mean, it's sad that I even have to talk about it, but I want to make sure that everyone is fully educated on just the different kind of facets when it comes to this diagnosis.
There are a couple in the Q&A that I can read for you, Danielle, a little bit like older questions, but still very applicable. So at what age is a child not affected by shaking?
There was actually a study, I think out of Saudi Arabia, where it was an adult female that was shaken and incurred injuries. It definitely is most common under that 5 age. There hasn't been a lot of case studies after that, but I know of at least one. So, but under that 5 is really when they're definitely at more risk.
Can another young child cause shaken baby syndrome on a sibling? Are young children strong enough to cause this damage?
I believe there was a case study on that. I think the child was a little bit older, 10, 12 years old. But I don't have those right in front of me. And I think I've only heard of one case study. You'll hear that sometimes, but it's kind of that differing history that doesn't quite match up. And so that's why there hasn't been a lot of case studies, because they can't really determine with fact that that's what happened or not. So it's a kind of non-answer. That was a non-answer. I'm sorry.
Kind of also just to kind of build off of that. So we talk about rough play and how although that can't cause these, effects, but it is discouraged. A lot of the time when like younger siblings are playing with their baby, that would be considered rough play. So just depending on, the severity, it is slightly discouraged, but there isn't any huge studies that show that that is what causes this type of abuse.
Well, and then too, again, kind of back to what you see on the street, when it comes to like shaken baby syndrome, it's a violent form. You're going to see that. Now, I'm not talking about other injuries. That rough play can easily cause broken bones, bruises, cuts, things like that aren't going to be obviously good for a baby. It could harm their development. So we tell people use your discretion. If you see something that you don't feel comfortable with or see unsafe, then definitely say something.
Awesome. Okay, couple more. So how far out from the occurrence can you diagnose?
So you mean like after a shaking incident, like can they go back and diagnose something a few years later? I don't know if that's kind of what you're referencing, I'm assuming.
Let's see. Yes, they said.
Yeah. So I know there are some, because the damage that's done to a brain, especially if there's skull fractures, if there's hemorrhages, you can see past bleeds, depending on if the body cleared up, how damaging it is, how big it is, and they might be able to identify past injuries. And again, it comes to history. A lot of abusive head trauma cases comes with a history of that child, what they've gone through. So I know we've had people reach out to us as adults inquiring if they can find someone who can tell if they've been shaken or not. That's a little more difficult because it's been 20, 30 plus years since their injury. They don't have the history associated with it. And the body repairs itself in different ways, especially as an infant. So it's kind of harder at that point.
Okay, and then last one is, can damage be reversed over time?
So I wouldn't say reversed. I would say that we know that especially younger infants, their brains learn a way, kind of workarounds, but definitely never reversed. There are a lot of good therapies out there now. There is a lot of good medical technology that can help stop symptoms from getting worse, can help treat symptoms, seizures, things like that, but definitely never reversed.
Okay, awesome. Okay, so let's go ahead and do another reaction. So if you are currently delivering or implementing a shaken baby syndrome education prevention program, go ahead and send a thumbs up. If you aren't or you're not sure, let's do thumbs down. And then if you are specifically using the Period of Purple Crying program, let's see a red heart. Okay, a little bit mixed, a couple of hearts. We love it. We love to see it. Awesome. You guys are so good at participating with reactions. I love this. I just love seeing all the little emojis like float up to the top. Okay, but so prevention, there is a need for prevention. There is a power in effective prevention. There are plenty of shaken baby syndrome prevention programs out there, but what is most effective method of not only reducing cases, but also supporting and educating families? So in the Abusive Head Trauma in Infants and Children technical report, they not only discuss new research on shaken baby syndrome, abusive head trauma, but they also mention prevention. So they emphasized the importance of supporting caregivers during early infancy, especially during those high crying periods that we talked about around that 2-month time frame. So they endorse evidence-based programs, which include the mention of the Period of Purple Crying program, which we'll talk a little bit more in depth in a minute, and its effectiveness at having positive impacts on parental knowledge of normal infant crying, and also how to cope with the frustration that crying can cause. It's important for prevention programs to include key components, such as education on crying, calming and soothing strategies, the dangers of shaking, and what to do when overwhelmed, and so much more. But there is an importance of having hospital-based interventions. In a perfect world, we would have universal delivery of shaken baby syndrome, abusive head trauma prevention materials in every birthing hospital, just as a part of discharge. But also having system level support where the program and messaging are also embedded into pediatric visits, community programs, home visiting, really anywhere that sees families with children under 1 year of age. But from various studies over the years on crying and infant research and abusive head trauma, we found that abusive head trauma is the only form of child maltreatment where we know the specific trigger, which is increased infant crying, and the timing of the incidents, which is around that peak 2-month time frame. So since we know triggers and timings, it can be prevented. And prevention really starts with educating parents and caregivers about normal infant crying and the frustration this crying can cause. So that's where the Period of Purple Crying program comes in. It is a program of the National Center on Shaken Baby Syndrome. It's based on over 60 years of research. The program itself has been studied for over 18 years. And the program really has two aims, which is to support caregivers in their understanding of early increased infant crying, and of course, to reduce cases of abusive head trauma. So the reason the program is called Purple is that each letter stands for one of the 6 features of crying in normal infants that contribute to the frustration and anger that the caregivers experience. So the first P stands for peak of crying, where the amount of crying infants experience naturally increases, peaks in the 2nd month of life, and then slowly decreases after that. U stands for unexpected, just referring to the fact that these crying bouts begin or end completely unpredictably and for no apparent reason. They're not related to dirty diapers, feeding, or anything else that's going on in the baby's environment. And R stands for resist soothing, when nothing a caregiver tries can calm the baby down. And the second P stands for pain-like face. Sometimes the infant can look like it's in pain even when it's not. L stands for the fact that these bouts are long lasting, averaging about 35 minutes per bout, but they can go on for as long as 5 hours a day or more. And the last letter, E, stands for the fact that the crying tends to cluster in the late afternoon and evening hours, often when the caregivers themselves are most tired and frustrated. But we then preface the acronym with the word period, just to remind caregivers that the crying does not go on forever, but only for a particular time period in the infant's life. So the real purpose of the Purple acronym is just to provide a quick, memorable, and easy way for caregivers to recognize and acknowledge that these crying characteristics can happen and they are completely normal. And while the acronym prepares parents for the crying characteristics, our crying curve prepares them for the timeline. So we know one of the biggest stressors for parents is the normal period of increased crying that all healthy babies experience. And so it's great for them to understand that the crying starts to increase at 2 weeks. It'll peak during the 2nd month and then slowly decrease after that. So it's important for them to know that the crying will come to an end. So what does the program information education look like? What are these newborn families receiving? So it comes in an app and booklet package. It contains a 10-page booklet, a unique one-time app activation code, and a parent reminder card. So parents are encouraged to download the app and set up an account by entering in the code and then choosing a login method. But they can also invite up to 5 other caregivers of their baby to access their profile on their own devices, just by a click of a button in the app. So this can include partners, babysitters, grandma, grandpa, really anyone who would be caring for their baby. And the mobile app talks about multiple different topics that are very important for these families to understand. So obviously we go through crying, but we also talk about soothing techniques, ways to cope with the crying, general infant safety, how to prepare your home for not only an infant, for toddlers. We go through safe sleep and even self-care for parents, because we know that they need all the support they can get during this phase in their infant's life. But the mobile app is currently in English or Spanish with closed captioning available. And while the mobile app is only available in those 2 languages currently, the booklet is translated into several other languages. And this includes French, Arabic, Haitian Creole, Somali, and hopefully some more to come. But so to ensure all parents and temporary caregivers receive and understand the Period Purple Crying program messages, the program encourages a 3-dose exposure approach. So to teach, reinforce, and advocate. So this helps ensure that all parents and temporary caregivers receive these critical messages, but also promotes a cultural shift in the way that the community views infant crying. So dose 1 is really the first initial education session where parents receive their materials, they receive an education through a trained provider, typically in hospital discharge, prenatal classes, home visiting, really anyone who would see them before 2 weeks old. Dose 2 is a reinforcement session. So parents are reminded of the information they already received. And if they haven't received the information, it's kind of a catch-all dose. So they can give them their program materials then as well. And that's usually done around 2 weeks to 3 months after the baby's birth. And it's, usually home visiting, pediatric visits, public or state or any other community programs that would see families after that time frame. And then dose 3 is just general population, so social media, flyers, anything like that. But the best thing about this program is it can effectively be delivered in as little as 3 minutes. And but it's important to have multiple organizations and programs within the community to deliver the same education. So all families can receive this initial information as well as reinforcement of key messages. So the Period of Purple Crying program has been tested for over 15 years and it has been shown to be effective. So it is recognized as an effective resource for organizations serving families under 1 year of age through multiple reputable organizations. So just one of them is the California Evidence-Based Clearinghouse for Child Welfare. It's a nationally recognized database that's driven to advance the effective implementation of evidence-based practices for children and families. And really it's designed to prevent abuse and neglect from occurring. And currently, Purple is the only abusive head trauma prevention program within the database that has research supporting its effectiveness at reducing cases. But so I'm just going to quickly go through these next 2 slides. It's just a timeline of the program and the evidence backing the model. As I said, the program's been studied for over 18 years. The program materials were made public in 2007. 2 years after they were made public, there was 2 parallel randomized control trials, and they showed that there was a change in knowledge and behavior related to the Purple program. In 2014, a study was conducted in North Carolina, and it found that parents reporting shaking as an appropriate form of discipline was reduced by 50% with the Purple intervention. And in 2015, Purple was found to decrease emergency department visits for complaints of crying unrelated to physical illness by 29%, which actually led to hospital cost savings of 18%. In 2018, one of the most important studies supporting the program was published. It was an 8-year outcome of implementation study, and it revealed that the Purple program was associated with a 35% reduction in abusive head trauma in children under 2 years old. Following this article, a cost effectiveness study was published, and it found that every dollar spent on Purple had an associated $54 savings by society, which you can compare to child safety seat loss. For every $1 spent, 42 saved, and even zero tolerance, where every $1 is spent, $25 is saved. Additionally, in 2021, a study was conducted on Hispanic mothers, and it found that their knowledge of normal infant crying patterns was improved through the delivery of Purple. And one of our latest studies, published in December of 23, found that hospitalization rates for general physical abuse in children under 2 years of age decreased by 30% in British Columbia after Purple was universally implemented. And I think we do have a Purple fact sheet that they will be dropping in the chat if they haven't already. And if not, it'll be in the follow-up email.
It's in there.
Perfect. Okay, so a study conducted on home visiting programs and the components that produce positive impacts on the program's effectiveness showed that the 3 most significant components in improving a home visiting program's effectiveness should include focus on improving parental expectations of the child and parenthood in general, targeting parental responsiveness or sensitivity to a child's needs, and video-based feedback. And the Period of Purple Crying program involves all 3 components. So some of you may be thinking that this is great information, but why do you have to buy the program? So the program does come in that app and booklet. It is $2.50 per copy, so it does have a price. And so some of you may be wondering why you have to buy the program. Why can't you just talk about, the crying curve or the acronym? But it's because not only is the program model research and evidence-based, but the use of the materials were tested in an 8-year study. And it was found that both mothers and fathers were found to increase the use of these materials during that high crying period at home, which was around that 2 months after delivery. So mothers' use of the materials more than doubled at home post-discharge, and 50% of fathers had read and viewed the materials by the 2-month mark. So that's why it's extremely important parents and caregivers have their own set of materials at home with them so they can review the information later, as well as share it with other caregivers of their baby. And although the program and prevention has a cost, it has shown to be very cost effective. So large financial costs are associated with abusive head trauma, and even a mildly effective case can cost over $1 million. So one major benefit to implementing Purple is it actually shows potential cost savings to not only the medical system, but to society. So to help your understanding of the cost of abusive head trauma, this graphic is specific to California. So the red line shows the average lifetime cost of a surviving victim, which costs well over $2 million to society. The gray line shows the cost of medical care alone for one severely injured victim from 2 months to 17 years of age. It was around $260,000, but half of that was paid out of pocket by the family. And now the purple line shows the cost to provide Purple program materials to every family with a newborn in California. And as you can see, preventing just one abusive head trauma case can pay for prevention and shows that it's very cost effective. So because we know prevention is a multifaceted approach and sorry, Danielle.
There's a couple questions about the Purple program, if you don't mind answering them. So there was some question about the app and if it's free or, who delivers that. If you could kind of just walk through when you mentioned like the cost, what that includes, and then what is complimentary from the National Center and kind of who covers that and just how that works.
Yeah, of course. So it is $2.50 per copy, which includes the app and booklet. So that's given to the family for free. It's purchased by whoever is delivering this program to the family. So, home visitors, hospitals, public health programs, whoever is wanting to deliver this prevention education would pay that cost. But through the National Center, the only thing you're paying for is the cost of materials and shipping. We provide free training, which includes continuing education. We provide webinars, updates. We provide, implementation protocols, talking points, really any support that you need to deliver this program effectively, we give to you for free. And so, that includes all those things I just mentioned, but also just like continued support. We have a grant template that you can use to apply for your own grants to help with that funding. We understand that funding can be a hurdle, but that's really the price all encompassing.
And just to clarify, when we talk about that app, so on the front of the booklet, there is a code, a 7-character code that's printed on that. And so in order to access that code, the parents will receive that booklet with the code on it. And then it's given to the families and they can access that code. And as Chantel said, it can be shared with numerous people. There's an invite caregiver feature on it. So you add a caregiver so mom can input information and dad can see it, babysitter can see it. So that's really great because we know mom is not the #1 perpetrator, but she's the one that usually is receiving the education. So just kind of that's a really important part of that. And as we continue to update the themes, I'll all the technology things associated with apps and everything. We're building in a feature to look at the analytics. So those codes are assigned to specific organizations. And hopefully in the near future, we'll actually be able to go and see like, okay, your organization, we had 50% open rate, or they visited this page the most, or they watched the video this many times. So it can just help reinforce either that A, your parents are liking the information, or B, there needs to be a change in delivery processes, things like that, and just kind of give us more of a broader picture of what we're doing and how effective we can be.
Right. Okay. Were there any other questions specifically about purple? No. Okay. Awesome. So, like I was saying, because we know prevention is a multifaceted approach, it takes a community, and we also have other great resources for organizations who may not serve families with newborns directly. And so, if it's not already, we'll have the link to our online training site dropped into the chat. But wanted to just talk about some of our other trainings, some of our other curriculum. So we have a school-based shaken baby syndrome abusive head trauma curriculum, and this includes it really actually it can be taught anywhere from 6th to 12th grade, and it can fit a 15-minute to even as long as a 2-hour classroom time. So it's really adaptable to what you want to teach to your students. It includes videos, interactive classroom activities, and a quiz. But so this really helps educate students about abusive head trauma and infant crying before they grow up and start having children of their own. And this curriculum is a one-time payment, and then you have access to the content for your classroom forever. On our website, we have a child care provider's intro to shaken baby syndrome, abusive head trauma training. This is online, but we also host 2 live trainings through Zoom each year. It's a little more interactive. You get to see some of our beautiful staff over Zoom and get taught the information that way. But it is also available on our training website. And if you do it through our website, it is available in English and Spanish. And it goes through the basics of shaken baby syndrome, the period of purple crying, ways to soothe a crying baby, how to cope with a crying baby, of course, safe sleep, and recognizing and reporting child abuse. And you know what? Let's go ahead and just do one more reaction. So if you got anything from the prevention portion of this training today, if you are planning on adding a new facet or a new part to your current prevention strategy, let's go ahead and do thumbs up. If you're not really sure or just kind of like no, go ahead and do thumbs down. Oh yes, we love the thumbs up. That's awesome. If there's a thumbs down too, that is fine, perfect.
We all have giant workloads.
Exactly. Yep. Okay, awesome.
So just some of the things, kind of doing a broader picture. So as we talked about in the technical part and a few other things, there is a broader approach to abusive head trauma, shaken baby syndrome prevention. It's educating parents using that universal messaging, that's consistent messaging, but it's also that support. We're talking about access to home visiting programs, paid parental leave, kind of support as a family as the whole. Legislation, there are some places that have phenomenal legislation that can be really effective, but also can be very hindering as well. So it just depends on kind of how that's written and if it's successful or not. So that's kind of some of the goals that we are always working on, that we're always encouraging our partners to work on, is this kind of multifaceted approach as kind of Chantel was alluding to. So some of the things we were talking about, national legislation, some things that have been done really well. Minnesota, one of their, and I don't think it's considered a mandate, but one of their policies is requiring hospitals or requesting hospitals to show a shaken baby syndrome video after the delivery of their baby. And then that video actually has to be approved by the commissioner. They approved 2 or 3, and purple is one of them, and the one that's mostly widely used. Their mesh home visiting, which is a component of the Department of Health, actually uses the period purple crying program throughout the state. Wisconsin actually has shaken baby syndrome prevention education for every birth in the state built into their budget. It's overseen by their Child Abuse and Neglect Prevention Board. And one of the biggest providers in the state is Children's Wisconsin Hospital. They deliver on all facets within the organization. So the emergency room, NICU, PICU, pediatric clinics, home visiting, anybody who interacts with a family or an infant under a certain age will receive the education, and then they'll actually receive reinforcement messages. So they can say, hey, I saw that you received the period purple crying program at your pediatrician's office, but you're here in the ER for either crying or something else. Let's just remind you about the period purple crying. And so that's been a really good system and model that they use. Another good example is Oklahoma. Oklahoma Department of Health has a program called Preparing for a Lifetime that's really focusing on improving infant and maternal outcomes. It is a state allocated fund that provides the materials to all the birthing hospitals and some home visiting programs, mostly the home visiting program that's run through the Department of Health. But that's overseen by the state, and that's been really successful. And they've been doing that for about 13-ish years or so. And it's been really effective. This whole program, the Preparing for a Lifetime, has been very effective on multiple levels. So that's just kind of a quick spattering of some of the efforts out there in the nation. One that we're working with closely is Florida. Florida has a high birth rate. They also have a high rate of abuse as well. So we have been working with the Prevent Child Abuse Florida chapter. We've been working with some state attorneys. They see, the state attorneys are seeing how many cases are appearing on their desk and what should have been done to help prevent these cases from ever reaching their field. And so they're working on doing some legislation. It didn't get passed. It kind of died in subcommittee last year, but they're redoing it again this year and really focusing on getting more messaging out there about the importance of getting some state mandates out there with allocated funding. So fingers crossed that it's more effective this year. So just another important thing I want to touch on again, and I know we've kind of mentioned this before, especially when Chantel was talking about purple, but the importance of consistent messaging, and that's on all levels. So just reiterating, anytime you work with a family, that early infant crying is completely normal. There's not anything wrong with you. There's not something wrong with your baby. Your baby does not hate you. We hear that a lot. And so just kind of reiterating that there's going to be times that you can soothe your baby and times that you can't. Something will work one day, something won't work the other day. And that crying is not the caregiver's fault. And they need to just understand that. It's okay to put that baby down and walk away. We call it kind of 3 action steps to take these action steps, but it's okay to walk away, put that baby down. And we always stay in a safe place. So that's a crib on its back with nothing in the crib. We're very strict on the kind of those safe sleep recommendations, but take a break. You know, we always say, calm yourself, go back and check on the baby. And if you still feel like you're frustrated, it's not time to pick up that baby yet. And then increase that carry, comfort, walk and talk actions. Those, you know, you don't need to buy some fancy noise machine or some fancy swaddler or this or that. You know, parents have those tools already built in. And we talk about that in programs, but in our purple program, but really just encourage parents to try to use those noises, that skin to skin, the sucking reflex, just the walking motion. Those can all be really effective, but no, it only will help about 50% of the time on those inconsolable bouts, not all of the time. Lastly, and most importantly, if they have concerns, it's still okay to take the baby to the doctor. If there is something wrong, they'll help identify it. And if not, they'll just reiterate that this baby's just going through some normal crying and it's okay. And again, this crying will come to an end. I mean, it changes into more of sassing and whining when they get into teenagers, but it's very different. I will tell you that as a parent of teenagers. So the universal support for families, I kind of want to talk about, I touched on this just slightly on that universal approach, but even economic support. There was a study by Joanne Clevins in California in 2016, and it showed that when paid family leave policies were implemented, there was a significant decrease of abusive head trauma. And then states that didn't have that paid leave did not see that same drop in cases. And then Similarly, those states that offered refundable earned income taxes saw fewer hospital administration admissions for abusive head trauma. And so knowing that financial stability, that time at home with newborns can really help prevent child abuse. And I still think our body of research for that is just growing. And I look forward to seeing what it shows us in the future. And that is it. What questions can we answer for you? Sorry, I know that was a ton of information. I felt like that me and Chantel just splurted out. But put any questions that you have in the Q&A. Our information is there. Feel free to email us if you think of anything afterwards. We're happy to answer. I know I've already talked to one person about more information I'm going to find out for him and get back to him on. But we're here for you.
I wanted to go ahead and say thank you both so much for being here today and giving us your expertise, talking us through things, and of course, having an abundance of resources for our community and our organizations that are serving these kiddos and families. So Lana will drop the link for you in the chat for the survey. I'm going to go ahead and hop off out of the attention so that way we can answer any questions in the meantime with the few minutes we have left today. And so thank you all for being interactive and giving the reactions and commenting in the chat. It's always nice to have good discussion while we're here in the virtual space. And so thank you all for being here today.